Welcome to today's eye review session. My name is Yejun Hong, a second-year medical student at the University of Calgary. Our team here will present to you today about AAION, Arteritic Anterior Ischemic Optic Neuropathy, as a link between ophthalmology and emergency medicine. The field of ophthalmology and emergency medicine is quite intimate. Around 2 million visits to the emergency department every year in the US are from ophthalmic conditions. And the topic we are going to cover today, giant cell arteritis, which is an arteritic AION, is an emergency. This is one of the reasons why people go to the ED. This unique and emergent ophthalmic condition, known as giant cell arteritis, is also associated with other medical fields as well. Polymyalgia rheumatica, which is a disease in rheumatology, is also associated with scalp tenderness and temporal pain, and indicated with vasculitis known as giant cell arteritis. Another link can be drawn between ophthalmology and neurology. GCA causes arteritic anterior ischemic optic neuropathy, or AAION. This is essentially an impairment in the optic nerve. So this is a disease that's quite mouthful. What is an AAION? So it's an arteritic category. There's also a non-arteritic AAION, but in this case it's an arteritic category of the ischemic infarction of the anterior optic nerve. Right? So there are vasculature feeding the optic nerve as well, and the anterior segment is suffering from ischemia. And there's an occlusion of the posterior ciliary circulation, which feeds the anterior optic nerve, and this is behind the lamina cribrosa of the optic disc. The arteritic classification is due to the giant cell arteritis that occurs. So with giant cell arteritis or temporal arteritis, you'll get scalp tenderness, the jaw claudication or tiredness from using the jaw repeatedly over a long period of time, and also temporal pain. Let's take a look at the vasculature where AAION and the GCA can occur. So there's the internal carotid artery leading from the heart all the way up into the neck and into the head. This turns into the temporal artery as it crosses the temporal area of the head, which then branches out into an ophthalmic artery and then to the posterior ciliary arteries that feed the optic nerve. People at risk of AAION are patients over the age of 55 or patients with polymyalgia rheumatica. Polymyalgia rheumatica is an inflammatory disorder that causes widespread aching, stiffness, and flu-like symptoms. And the most common presentation of polymyalgia rheumatica is the pain and stiffness in the shoulder muscles, as well as the necks and the hips, and also the morning stiffness. A main symptom of AAION that we should note is dyschromatopsia, or the loss of color vision. However, because AAION is often associated with giant cell arteritis, we can look for the presentations and indicators of GCA to also have suspicion for AAION. The classic triad of GCA presents with first the scalp tenderness, or the pain upon touching the scalp, especially the temporal sides, jaw claudication, so the tiring of the jaw after a patient talks for a long time or eats a big meal, or headache along the temporal sides. GCA, because it is an inflammatory condition, can present with B symptoms as well, such as fever and weight loss. It also presents with diplopia, or double vision, as well as amaurosis fugax history, which is a fancy term for episodic vision loss. Those symptoms I have mentioned are all associated with GCA. AAION can also be associated with polymyalgia rheumatica, which is a rheumatic disorder. And to check for that, we ask the patient and check if they can extend their arms beyond 90 degrees. If there's joint pain or even inability to do that, there is a good chance that the patient may have polymyalgia rheumatica. And this should raise your suspicions toward AAION as well. With AAION testing visual field, you'll notice that the patient often has central or altitudinal visual field defect. Upon observing the pupils, the patient will have an RAPD, or a relative afferent pupillary defect. This can be confirmed by a swinging flashlight test. While normally on perception of light and stimulation of the optic nerve after that, the pupils will constrict in response. However, if the light sensing system, the cranial nerve 2, is impaired in the other eye, upon shining light at that eye, the fellow eye will receive less light in comparison. This will result in dilation of the pupils instead of the maintenance of constriction. When observing the back of the eye with fundoscopy, there may be swollen optic disc as well as swollen and tender temporal artery upon physical exam. On back to fundoscopy, you'll also find cotton wool spots indicating ischemia, and in the late stage, you'll find optic disc cupping and elevation. With these symptomologies, AAION has a lot of differential diagnoses. It can be malignant hypertension, which is resistant to a lot of hypotensive meds. There could be diabetes mellitus, retinal vascular occlusion, the BRAO, compressive lesion from the back of the eye. There can be collagen vascular disease, always syphilis, as well as herpes zoster. Systemically, there can be migraine or massive blood loss that can cause these symptoms, and also normal tension glaucoma can present with decreased vision or constricted visual fields in the late stage. When taking history to rule out AAION, ask about the symptoms that have been covered on the previous slide, and also pay attention on the drug history and specifically screen for erectile dysfunction drugs and amiodarone. For medical conditions, start with open-ended questions, but ask if the patient has OSA, or obstructive sleep apnea. Then, a thorough slit lamp exam to rule out any other pathologies would be helpful, and an Amsler grid to see if the visual field is coherent and there are no missing parts within the visual field would be prudent as well. But the most important part of the physical exam for AAION are the afferents and the efferents. Afferents test for the visual acuity, the color vision, which would be altered if the patient presents with dyschromatopsia, the visual fields, RAPD, and the fundus exam. The efferent exam consists of checking for extraocular movement, if the eyes are motile, looking at the alignment of the eyes in any position, comparing the size of the pupils and their reactions at the light, at the dark, And in accommodation, or focusing on close-up objects, we can observe the lid for ptosis and lid lag. And lastly, checking for saccades or nystagmus with Frenzel goggles would be effective and important ophthalmic exams. If you're suspicious that the patient has AAION, ESR and the CRP is crucial. We should investigate those two markers as soon as possible. In terms of vitals, we can take blood pressure. That's especially important. We can also order CVC, look for low hematocrit and high platelets as an acute phase reactant. Also look for fasting blood glucose for diabetes mellitus possibly, and VDRL and FTA absorption test for syphilis, and ANA for vascular inflammatory disease. The investigation of AAION includes a temporal artery biopsy. The biopsy is taken bilaterally and at 2 centimeter chunks. The reason that it is that way and such big biopsy is taken is because the nature of the lesions are skip lesions. So they may not be continuous along the temporal artery, and if we are unlucky, we may accidentally biopsy the normal presentation of an artery between the skip lesions. Fluorescein angiogram would also be a good test to find out if the patient has AAION, and if the FA returns with choroidal infarcts in its results, that is pretty indicative of AAION. The treatment for AAION is administering systemic steroids. So specifically methylprednisolone 1 gram IV per day times 3 days. But before we administer steroids, we will check the blood glucose as well as chest radiographs before that. The reason for that is steroids raise blood glucose and lowers the white blood cell counts. If the patient's blood glucose is high already, steroids may cause an adverse effect on the body, and therefore reducing the blood glucose before administering steroids would be important. And chest x-rays are checked to see if there are infiltrates or masses in the lungs. If the patient has pneumonia or even lung tumors, then the immune system is needed more than ever. However, steroids have an unfortunate effect of suppressing the immune system. So, knowing that patient has pneumonia or lung cancer would prompt us to adjust the treatment course or administer additional treatments to address those problems. Once the systemic steroids are cleared for administration, after the methylprednisolone for 3 days, you can give prednisone 60 to 100 milligrams per oral per day with a slow taper. We can't suddenly just stop that amount of prednisone so quickly, so we decrease by 2.5 to 5 milligrams at most per week. Because AAION is an emergency, we start before the biopsy results are returned, and H2 blockers or PPI can be given along with the systemic steroids. because systemic steroids may cause stomach ulcers. Unfortunately, AAION has quite a bad prognosis. The visual recovery is rare, and the treatment will hopefully prevent the progression of the visual impairment. And the fellow eye is also involved in 75, 3/4 of the cases, and if not treated, as quick as within 2 weeks. Here is a well-drawn flowchart to demonstrate everything that we've learned in this presentation. And here are the references for that we've used to compile all the information in this presentation. Thank you for watching this video.